Hello, everyone. It's my pleasure to be speaking to you today about stem cell transplantation for MDS. My name is Bart Scott. I work here at the Fred Hutchinson Cancer Research Center with Dr. Deeg, and I've been asked to speak to you today about stem cell transplantation for MDS. So we'll review the transplant in general, what it is. We'll talk about how we select donors. We'll discuss the impact of age on transplant outcomes. When should transplant be considered for MDS? Should we give treatment before transplant or not at all? And then we'll discuss the role of conditioning intensity. So as review of transplant, I think it's important that you have some basic understanding of what we call HLA. So HLA stands for a human leukocyte antigen, and you get that from your mom and from your dad. So here we have a mom and a dad and 4 children, and you see that there's 4 different pairings that are possible from your parents. So each sibling has roughly a 25% chance of matching the recipient, who would be the patient that's receiving the transplant. At this point in time, we still prefer sibling donors, and we still prefer matched unrelated donors, but I'll discuss alternative donor selection at a later slide. This HLA is carried on chromosome 6. Of note, it's not related to blood type, which is on a completely different chromosome. So it has nothing to do with blood type. Your donor could have a different blood type, but still be HLA matched to you. The way we do a transplant is we give you some type of a conditioning regimen. Now, when transplants were first developed, it was thought that we gave the stem cells to rescue patients from the side effects of high doses of chemotherapy or radiation. So the idea of stem cell transplantation was, let's give high doses of chemotherapy and radiation. Unfortunately, stem cells die. So a common side effect of high doses of chemotherapy or radiation is that it kills the stem cells. So you need to give new stem cells from a donor to rescue patients from the side effects of the high dose chemotherapy or radiation. But we actually now have a greater understanding that the stem cells themselves can elicit an immunologic attack against the cancer. We call that a graft versus tumor effect, GVT. It's sometimes called GVL as well, graft versus leukemia effect. But there's actually an important component of the transplant where the donor cells can attack the stem cells and destroy them. Now, the donor cells can also attack the patient. That's called graft versus host disease. So as physicians who specialize in stem cell transplant, we're always trying to balance the benefit of this graft versus leukemia effect with the detriment of graft versus host disease. And as you can see, it is a delicate balance. Now, as I mentioned to you, previously we would give very high doses of conditioning, which are shown here on the far right-hand side. But the knowledge that the donor cells are effective have led to what we call reduced intensity conditioning regimens, which are shown here on the left-hand side. As you increase the intensity, the required contribution of the graft versus leukemia effect diminishes. So one of the things that you're going to see is that with these lower intensity conditioning regimens, there's less toxicity, but there's also a higher risk of relapse. And we'll go into some more detail about that later on in this talk. Now about donor selection. This is one of the new studies that came out recently where we looked at patients who had no matched donor. So they didn't have a matched sibling donor or a matched unrelated donor. And they were randomized to either receive an umbilical cord blood donor or a haplo donor, which are shown in these 2 boxes. So this is considered to be a very good way to do a study to randomize patients because it removes the bias of selection. There are a lot of criticisms of this trial, and one of them is that there's a variety of diagnoses that were chosen. So it includes both acute leukemia or lymphoma. We have a wide age range group here of 18 to 70. It was considered an intent to treat analysis, and there were some patients in both groups who did not receive transplant. You're going to see that in most of these types of transplant studies, where not everyone is actually able to make it to transplant. And you can see that the most common reason is relapse. So 10 here and then 8 here. And then, just about the intent to treat analysis, invariably there are some patients who actually end up not getting the intervention you planned. So there are 11 of the haplo patients got cored, and then one of the cored patients got a haplo. Haploidentical is basically referring to a sibling or a mother or a father who's half matched to the patient. So that's what the haplo is. And of course, umbilical cord blood would be cells that are stored from newborn infants. So we take both the placenta and the cord and we store those. So they're stored products. When you look at the relapse incidence at 2 years, it was similar between both. But when you look at the overall survival, it was better with haplo bone marrow compared to cord blood bone marrow. And this is chiefly because of increased infectious complications in patients who received umbilical cord blood donors. So it's not a difference in the risk of relapse, it's really a difference in what we call treatment-related mortality. So there are more patients who died of infectious complications who got umbilical cord blood donors. There is actually an interest in looking at haplo bone marrow versus unrelated donors. But right now, our preference algorithm is sibling first, matched unrelated second, and then if we're not able to get a donor for both of those situations, then based on this, haplo donors would be preferred, although we still do have some umbilical cord blood protocols that we're doing in special circumstances. I would say that based on the results of this study, most centers have switched to primarily offering haplo. Other advantages of haplo is that from a logistical perspective, they're a little bit easier to perform. So the idea that we can't find a donor for patients is not necessarily true. It might be more appropriate to say we can't find the most preferred donor for a patient. So I'm just saying that lack of donor availability, in my opinion, is no longer a strong argument for not doing an allogeneic transplant. Now moving on to a different topic which is important for the consideration of transplant for MDS in particular is something called ageism. So unfortunately, patients can be discriminated against for a variety of reasons. Obviously, we know many of them, but one of them is age. And older patients are more likely to die from transplant. They have less benefit due to advanced age. There may be more effective therapies for these patients, such as hypomethylating agents, and there are issues with cost and healthcare resource utilization. So this was a prospective study from the CIBMTR, and this was what we call the Medicare coverage study, but essentially Medicare wanted evidence that allogeneic transplantation was beneficial to older age patients in order for them to continue to support coverage for transplant in patients over age 65. So this was a prospective assessment of outcomes for patients specifically with MDS. And you can see that there were 688 patients over age 65, and there were 592 patients less than age 65, but older age 55. And you can see that there was no difference in outcomes with allogeneic transplantation. Here's the statistical comparison, but you can look at these curves from a non-statistical point of view and kind of figure they're pretty similar. So on the basis of this trial, Medicare has continued to cover allogeneic transplants for patients over age 65, and age alone should not be considered a contraindication for transplant. It is a consideration, and so it's a complicated decision model, and it is one of the more difficult conversations that I always have with patients, because certainly there's a lot of upfront toxicity with stem cell transplant, and it's a big commitment. So I am not here saying that everyone over age 65 should be should have a transplant. But what I'm saying is it should be considered, and that age alone is not a contraindication. One of the issues with age is that we do have to use what we call a reduced intensity conditioning regimen, which I spoke about a little bit earlier. And what you see with reduced intensity conditioning regimens, at least based on retrospective assessments, was a higher relapse rate, but a lower non-relapse mortality or treatment-related mortality. So that when you looked at overall survival, it was pretty well balanced. Now, this is what we call a retrospective comparison. So that's retrospectively looking at data. It's not a prospective randomized trial. So the quality of the evidence is less. But based on this, it was thought that the overall survival was similar between reduced intensity conditioning and high dose intensity conditioning. So when should allogeneic transplant be considered? There are certain clinical situations where I think patients should be considered for transplant. One of them is if they failed azacitidine. Now, these are retrospective assessments, so admittedly there is some selection bias present, but the best survival was seen with allogeneic transplantation for patients who had high-risk MDS who failed azacitidine. Now, these patients were likely younger. They were likely of a better performance status, so there might be some who argued that it's not the intervention of transplantation that led to the better survival, but the fact they were selected for this. You see very similar data with low-risk MDS. So if you have a low-risk MDS patient, SCT is stem cell transplant. They had the best benefit with stem cell transplant. So based off this, I would argue that if patients have low-risk or high-risk disease, MDS, and they fail hypomethylating therapy, certainly allogeneic transplant should be considered at that point. What about upfront? So there are several, 3 to be exact, prospective biological assignment trials that have evaluated the impact of stem cell transplant as an upfront therapeutic intervention for patients with MDS. This is from the GFM group. It's called the Group Francophone Myelodysplasia, but it's the French MDS group. And they were one of the first studies that was published that assigned patients to either the no donor group or the donor group. And you went into the donor group if you had an HLA-matched sibling or unrelated donor. And there were 112 patients in that group. The upper age limit was 70. So they're basically saying that if you're over age 70, we did not consider transplant for you. If they had no donor, meaning no sibling donor, no unrelated donor that was matched, they didn't do cord blood or haplodonors. They primarily received hypomethylating therapy. And there were 50 patients who fed into this group. Now, you had to have higher risk disease in order to be eligible. It did include a variety of different disorders, MDS, AML, and CMML. If the blast count in the marrow was less than 10%, then you went straight to transplant. But if not, they gave you some type of cytoreductive treatment before transplant. And there are slides later on in my talk that discuss this in greater detail. All patients received a reduced intensity conditioning transplant. And all patients received peripheral blood stem cells, no cord, no haplodonors. This was an intent to treat analysis. So if you had a donor, you went into this donor group, whether you received transplant or not. There were 31 patients who had a donor that actually did not get the transplant. And it's mostly because they had refractory disease. They had progressive disease. So if patients are rapidly progressing, you can't go into the transplant. So that would essentially mean that the induction chemotherapy, which is IC here, or the azacitidine, really didn't work to control their disease. But as I said, it's intent to treat. Regardless of the fact that 31 in the donor arm didn't get transplant, there was still a survival benefit in the donor arm compared to the no donor arm. So it was good to have a donor. Now, you could look at it that way, but really what this is saying is that it's good to undergo stem cell transplant because having a donor doesn't change the natural history of MDS. It's the intervention that was performed because you had a donor. And this was significantly different. We say a p-value of less than 0.05 is considered to be medically different. Now, there are some important things to know about this data. And one of them is that obviously these curves did not start to separate until after 2 years. And that's because of the increased early mortality with allogeneic transplant. So these are patients that are dying from the intervention itself. But eventually, there are some patients who are cured. Now, I think it's appropriate to say that if you were to ask a patient which one of these curves you want to be on, neither one, please. Well, we're all trying to get better. So as Dr. Kamraji will likely mention, hypomethylating agents, we're looking at several different combination strategies to try to improve this number. We're also looking at different types of conditioning regimens to try to make this number better as well. And we're also looking at maintenance strategies after transplant to try to make this number better as well. So we both have arguments, both transplants and non-transplant physicians have arguments to say that our interventions are now better. What we can say is at this point in time, the transplant group did better than the non-transplant group, but only after 2 years. That tells you something about who should be selected for transplant. If you have a patient whose survival is otherwise estimated to be less than 2 years, meaning they have a lot of comorbidities, I would say that's probably not a patient that should be considered for transplant. This was a very similar type of study. It's called the VidazaAllo Study. It was done primarily through the EBMT, the European Bone Marrow Transplant Group. But again, this was a no donor versus donor comparison. So the donor group had an HLA-matched unrelated donor or matched sibling donor, and that's listed in red. And the no donor group had no matched unrelated donor or unrelated donor. Related or unrelated donor. That's shown in blue. All patients received 4 to 6 cycles of azacitidine, and if you had a donor, you went through transplant with reduced intensity conditioning. 7% of patients died with infections in the initial phase. 16% of patients progressed in the initial phase. So around 23% of patients ended up not being assigned to continue the Vidaza or undergo transplant because of immediate complications from the transplant itself. And 14 patients in the AZA arm received alternative donor transplant. So they weren't supposed to do that, but they did it anyway. But it's an intent to treat analysis. Despite this, they showed very similar findings to the previous study, better survival if you have a donor than if you don't. But again, look at this. It doesn't start to separate out until after 2 years. And now here you're really seeing that early mortality from transplant. So there is an upfront risk, but a later benefit. And some patients can be cured with their MDS with stem cell transplantation. But again, you don't start to see the separation until after 2 years. This is also a very similar study. This is from the CIBMTR, which is basically the American Transplant Group, Center for International Bone Marrow Transplant Registry, through a trial called the BMT-CTN1102. We participated in this study, enrolled many patients into it, but it's a very similar type of design. If you had a donor, unrelated or sibling, you went to transplant. If you didn't have a donor, then you got other therapy, and most of that's going to be hypomethylating treatment. So it's basically hypomethylating treatment versus stem cell transplant. Invariably, some patients in the transplant group didn't go to transplant, and some patients in the no donor arm group did receive transplant. So you're always going to see those types of things, but very similar findings to what was shown previously, which is that in the first year with this study, survival is very similar, and you don't start to see clear separation until around 2 years out. So again, just saying, better to have a donor than a no donor, and the benefit of transplant is not immediate, it's delayed. Regardless of which subgroup you looked at in this BMT-CTN1102 study, there was a better outcome with transplant versus not transplant. So that's older patients, that's patients who had no prior hypomethylation therapy or who did, patients who have very high risk or high risk. So all of these groups benefited with transplant. Shifting gears, a new topic is, what's the best way to prepare patients to go to transplant? And the idea is that you can take MDS patients who are untreated and go directly into transplant, or you can give them induction therapy. And this retrospective analysis from the Italian transplant group showed no benefit with giving induction therapy. If you're in remission after induction therapy, you have a similar outcome to untreated patients. Now, a big caveat here is that this was a retrospective assessment. And so people who believe that there's a benefit in giving treatment would say the reason why these patients had a similar outcome to untreated patients is that patients with worse disease were chosen to get induction chemotherapy. And so really, this should be considered to be a positive finding, Because what you're saying is that you can take patients with very bad disease, give them induction chemotherapy, and give them an equal outcome to patients with better risk disease. That's the way people would look at this study who believe in the benefit of giving induction chemotherapy. This is comparing hypomethylating agents to induction chemotherapy. What I can say is that most of these studies had a common finding, which is that there didn't appear to be a big difference in outcomes between whether patients received azacitidine or chemotherapy before transplant. So that has led to an interest in doing a randomized study, which we're almost done with, where we compare azacitidine to induction chemotherapy in a randomized fashion before stem cell transplant. The primary endpoint is 18-month overall survival post-transplant. All right, so moving away from giving pre-transplant therapy to conditioning regimens, I mentioned that the available evidence had indicated equivalent outcomes between what we call reduced intensity conditioning and high dose intensity conditioning. So these are the reduced intensity conditioning regimens. These are the high dose intensity conditioning regimens. We did a prospective randomized trial looking at these two different regimens in patients with MDS or AML to try to answer the question, is RIC regimens better than what we call MAC regimens? And in a randomized study, you're going to see that they're fairly well balanced between all of these different factors. The conditioning regimens primarily chosen were 4-day busulfan and 2-day busulfan. So it's 2 days of busulfan, which is the chemotherapy that we give before transplant, versus 4 days of busulfan. And what we found is that there was a better survival for patients who got high-dose intensity conditioning. And that's primarily because of relapse. So the relapse rates in the RIC arm were much higher than what we had expected. And also, the treatment-related mortality in the MAC arm, the high-dose intensity, was lower. So what this tells us is that we've gotten better at doing transplants over time with high-dose intensity conditioning. So when you look at the relapse-free survival, there's a big difference here with better relapse-free survival in patients who got a high-dose intensity conditioning regimen in comparison to patients who got a low-dose intensity conditioning regimen. And look at these relapse rates. So much higher rates of relapse with reduced intensity conditioning. The treatment-related mortality was slightly higher in the myeloablative arm, but it was lower than what we had historically seen. Historically, we had seen rates almost as high as 30% at 1 year. And here you're seeing rates of about 10% at 1 year. So the myeloablative regimens performed better in regards to treatment-related mortality, which is what we think really drove this benefit from myeloablative conditioning. When you look at the cause of death, the chief cause of death for patients who got a reduced intensity conditioning was relapse, and the chief cause of death for patients who got a high-dose intensity conditioning was graft versus host disease. And remember, that's where the donor cells attack self. We found that patients who have residual disease, this is called NGS. Now, again, this is another word for mutational testing. So it's called next generation sequencing. Like I said, we do try to make it hard for you guys, but NGS is also mutational testing. So what we're saying here is that if you still have evidence of disease and you're NGS positive and you got a myeloablative regimen, there was even more of a benefit with giving high-dose intensity conditioning. So it's basically arguing that if you still have disease present, you should definitely try to get a high-dose intensity conditioning regimen if possible. And regardless of what type of mutation you had, even TP53, which is one of the worst, there were lower relapse rates in patients who got high-dose intensity conditioning compared to patients who got low-dose intensity conditioning. Now, I just want to quickly go through these. I'm not going to really discuss this in detail. There's different choices for reduced intensity conditioning. This was a retrospective comparative analysis comparing 2 days of busulfan to melphalan, and melphalan was the better choice in regards to lowering relapse rates. And the treatment-related mortality was a little bit higher with melphalan, but the disease-free survival was better and significantly better. So if you are a patient who needs to get a reduced intensity conditioning regimen, melphalan is probably the better choice. So in conclusion, alternative donor options are effective. Age alone is not a contraindication. If you have a patient with high-risk disease or intermediate 2-risk disease and they're a transplant candidate, that should be done. If they have lower intermediate 1-risk disease, transplant should be delayed. If patients fail hypomethylating agents, transplant should be offered when possible. Reduced intensity condition regimens do have lower toxicity, but at the expense of higher rates of relapse, and in general, higher dose-based conditioning regimens are preferred. If a patient cannot receive a high dose-based conditioning regimen, Flu-Mel is likely a better choice than 2-day busulfan. And with that,